Dear colleagues, let me introduce myself. My name is Boglárka. I am from the Városmegyi Heart and Vascular Center. I am a part of the heart failure study group, and my vision to help heart failure patients receive the most effective evidence-based therapy, and my mission to conclude from observations which we can include in the everyday clinical practice. My research topic is based on heart failure. I would like to evaluate the heart failure device treatment, especially cardiac resynchronization therapy. So my specific goal was to do two studies. One is about the cardiac resynchronization therapy, and the second is about the heart failure patient remote monitoring system. And I would like to discuss later about this topic. So my first topic is the benefits of adding a defibrillator to cardiac resynchronization therapy. It is a systematic review and meta-analysis. So this is my progress. We get revision from the Europe's journal, so we should send it until July. So, some thoughts about the background. Cardiac resynchronization therapy with or without a defibrillator is an effective therapy in selected patients with heart failure and severely reduced left ventricular function. However, the benefit of the CRTD over CRTP is still unclear because there have been no randomized controlled trials designed to compare these two treatments. While CRTD may further improve the survival over CRTP by reducing arrhythmic death, it does also add defibrillator-specific risk, such as lead failure and inappropriate shocks, as well as costs. So our aim was to evaluate the long-term benefit of adding a defibrillator to cardiac resynchronization therapy and to compare this with the cardiac resynchronization therapy with pacemaker regarding all-cause mortality and cardiovascular mortality. So our clinical question was, is there any benefit between these two therapies? Here you can see our PICO, and our hypothesis is that CRTD is superior to CRTP. So we conducted the systematic search. Here you can see our search key. And after the searching part, we have 29 full text eligible full text for our analysis. So I would like to present our results. The first outcome was all-cause mortality based on adjusted hazard ratio, because we have to know that these patient population are a little bit different. So CRTP, so there is a selection bias between these two therapy. Sometimes the operators would like to implant the CRTP for older patients. So we wanted to see with this with adjusted hazard ratios, and we can see that the hazard ratio is 0.82, and there is a significant difference between the CRTD and CRTP regarding all-cause mortality. So CRTD is better over CRTP. There were 8 articles compared these two therapies and with propensity score matching. And we can see also that the hazard ratio is 0.83. CRTD can be better over CRTP. We also evaluated the subgroups, non-ischemic and ischemic patient, because it's really important. Sometimes ischemic patients have a higher scar burden, and for this patient, defibrillator can be beneficial because of the sudden cardiac death and malignant arrhythmias. And we can see that the hazard ratio is 0.79. So the CRTD can reduce the mortality over CRTP, but regarding non-ischemic patient, there was no difference between the CRTD and CRTP. The reason of this finding may be that for this patient, the left ventricular reverse remodeling due to CRT and improving of the left ventricular systolic function could be better. So this can be the reason for this finding. And we also evaluated the older patient. And we can say that there was no difference between the two therapy regarding older patient. The reason of this finding may be that in this patient population, the leading cause of death could be based on the comorbidities. So there was no beneficial effect of defibrillator for this older patient group. So the strengths of our work, we could analyze a lot of patients. We could analyze 8 articles regarding the propensity score matching, and we could perform subgroup analysis also. And as you can see, this GRASS article has a huge impact on the results because there are a lot of patients in this article. So these are the limitations, and only observational studies were assessed because there were no randomized control trials on this topic. So our conclusion, CRTD is superior to CRTP regarding all-cause mortality. It could be beneficial for ischemic patients, but patients above 75 years couldn't benefit from CRTD compared to CRTP. And for the implication for research, it is essential to define subgroups who can benefit from CRTD implantation more precisely. And our second project is continuous invasive remote monitoring in patients with heart failure compared to regular in-clinic follow-up. So annual hospitalization related to heart failure in the USA and Europe are estimated to be over 1 million. And remote monitoring in heart failure patients is an approach used by clinicians to enable earlier interventions in cases of disease progression. However, the guideline is recommending remote monitoring at a high level, but there is no exact evidence for using it. And remote monitoring is underused in Hungary yet, but it would be significantly reduce the burden on hospitals. Our aim was to assess whether the use of continuous remote monitoring in heart failure patients leads to reduction in all-cause mortality, heart failure hospitalization rates, and cardiovascular-related hospitalization compared to standard of care. So our clinical question is continuous remote monitoring for heart failure patients is an acceptable alternative to regular in-clinic follow-up, and our hypothesis is that it is non-inferior to standard of care. Here you can see our preliminary research, and there are 15 eligible full-text articles for our study, and I would like to show our results. Regarding all-cause mortality, we can see that it's beneficial to remote monitor this heart failure patient long time. Regarding CV mortality, also see better effect for remote monitoring. The hazard ratio is 0.81. And CV hospitalization and heart failure hospitalization, there is no difference between the remote monitoring and the standard of care. Inappropriate shocks, there was also no difference between the two methods of following up. And our strength, only RCTs were assessed. We have several additional outcomes, not presented any meta-analysis before, but we should know that there are heterogeneous study cohorts and unstandardized alert actions, which is the reason we cannot prove the beneficial effects of remote monitoring and in every outcomes. So our implication for practice, if there is an opportunity to provide the patient home monitoring system, it can be an excellent way to enable earlier intervention in cases of disease progression. And we should design and perform a study where is a really fast reaction to the system alerts and to prove these beneficial effects of remote monitoring. Yeah, so thank you for your attention. And this is my favorite quote. Thank you.
This is a very interesting topic, and of course, it's not easy. There is an ongoing discussion in the medical field among cardiologists when and how these kind of devices should be implanted, what is the benefit. In particular with ICDs, there is a kind of turmoil, if I may say so, on the added value. And if I understood correctly the literature, many people believe that on top of the standard medical care, for a certain group of patients, the added value is questionable for ICDs. So we are not speaking about CRTs, but some kind of implications can be transferred to CRTs as well, if I am correct. Like ischemic cardiomyopathy is, of course, a prime target for this kind of devices because of fibrosis, as you have just said correctly. And the problem is maybe more complicated with DCM, where such kind of morphological alterations are hard to find. And then there are some scoring systems which help also to decide for ICDs. Do you aware similar applications for CRTs? This is my first question.
CRTP and CRTD? Mm-hmm. So the guideline said just a suggestion which patient should get a CRTD. So for example, if this patient is an ischemic cardiomyopathy or the life expectancy is better than 1 year or fewer comorbidities are, or a very young patient would like to implant a CRTD, but for the patient with a lot of comorbidities, a life expectancy is lower than 1 year, cachexy, frailty, and also renal kidney diseases, and older patients would like to implant CRTP, but I think also in our hospital it's always on the decision of the physician. So there are just a suggestion in the guideline. So it's a hard decision, and every physician like to do in their way. So,
but this is also a potential for you to clarify this field and give clear guidance. And this is why this kind of studies are beautiful. So congratulations for choosing this difficult field, because if you find a difficult job, then there is space for you. With regards to CRTs, a little bit more specifically, if I'm not mistaken, they are considered during left bundle branch block. Correct me if I'm wrong. And with regards to the extent of QRS prolongation, maybe the patients are not uniform. And so some may believe that the longer the QRS, the worse the prognosis. Did you pay attention in your analysis to this parameter, to the duration of the QRS complex among those studies that were included in your meta-analysis?
Unfortunately not, and it was not our aim in this study, so it would be really interesting, but it was not our aim in this meta-analysis.
Were these parameters available?
In some studies, yes, but in some studies we can't find these parameters. So these are observational retrospective trials, so it's hard to find sometimes this LBB measurement or QRS measurement retrospectively.
Thank you for the presentation. I would like to add just a short question that you said that above 75 years old people there is no difference. Can you tell or just guess what could be the reason behind this? There is no difference between the two technology.
So I think that for this patient, the leading cause of death based on the comorbidities and and the heart failure progression. So not because of the sudden cardiac death or malignant arrhythmias. So this can be the main reason for this finding.
So it basically means that in this patient population, there is no reason to implant these kind of things, right?
Based on our study, yes. So the suggestion is yes, but as I said, the guideline also give a suggestion, just a suggestion. So because we have no randomized controlled trials, we are not sure about this. These are observational trials. Yeah.
Just one more question there. Is there any risk to use the CRT with the CRT-D compared to CRT-P?
So the cost is bigger for CRT-D than CRT-P. So it's a financial decision also, and there are a lot of, or not lot of, there are some risk. For example, the shock electrode is much larger than a conventional pacing electrode for the CRT-P. So there are fractures, problems with the lead. The infection rate can be higher. So you should think about these factors also for an older patient. And this is a big procedure.
So it's quite obvious that these patients received different medications. So did you see or did you encounter into your analysis what type of medication the patients did? For example, I suppose some of the patients get amiodarone, other, preventing arrhythmias or treating the heart failure. So how does it show up in your meta-analysis?
So we just did a small table to show the drugs and how many patients get, for example, amiodarone or something, but we didn't do any statistical analysis with that. But we have not on the TMP, but we had a retrospective analysis on our clinic comparing CRT-P and CRT-D, and we did also statistical analysis to compare also the drug treatment, and there was no difference between the added drugs, so between the CRT-P and CRT-D arm. If I can say something, I'm not added into the presentation, but about the drugs. So the heart failure drug treatment are very improving nowadays. So a lot of new drugs are coming, for example, SGLT2 inhibitors and ARNIs, and these drugs can lower also the sudden cardiac death. So it will be an interesting question on the future that for this patient, with the years, the sudden cardiac death rate and also malignant arrhythmias can be lower with these drugs. So CRT-P and CRT-D question can be also a really good question on the future.
It's a basic information, and you might have mentioned, and if you did so, I apologize. But I would like to know a little bit more about your heart failure patients that were included into the two major arms. Were they all systolic heart failure patients, HFrEF patients, or some HFpEF patients were also included? Or
only HFrEF patients.
And
because
with regards to the rejection fraction, can we know a little more data?
The main thing, we implant CRT below 35% ejection fraction. So all of the patients were above this range, and I think the mean ejection fraction, or we didn't calculate it statistically, but the mean was from 25 to 30. So bad ejection fraction population.
So all those studies that were included, this was the,
maybe
there was no difference in that respect.
Not so much. Not so much.
Okay, thank you very much.
Could we please go back to the slides regarding the
Of course.
forest plots?
Yes. Which?
To the first one. Do them one by one.
This is the first.
Yes. So in general, what I really liked is that you have clear questions and all your conclusions were supported by your outcomes, which depends on the topic often, because it's not always straightforward, and also that you had the RCTs. We still see here quite a heterogeneity. Do you have any idea what could be the reason for that? What could be the source of this wide range of study level outcomes?
Yeah. So, for example, these are I think almost the whole study, and this contains also non-ischemic and ischemic patients. So the Lash Farkas was a non-ischemic patient population, so CRTP or CRTD was no benefit.
Could you repeat the last sentence because I couldn't hear it?
So the Lash Farkas was a non-ischemic patient population, so in this population there was no beneficial effects, the CRTD over CRTP, and for example, the Auricio, it was a really old study, Auricio, and on this era, the drug treatment was not so improved, so the sudden cardiac death rate was a little bit higher also in the so the CRTD have a better effect for this patient population. So these are a little bit heterogenic population in these articles.
Which is not necessarily a disadvantage, I think, because that still underscores the results. And what is really nice here is that you have many study level outcomes which are not significant, but your overall result is significant, which is basically the point of a meta-analysis. And what might have been interesting, I don't know if you could include it, but it could be interesting to make like a development, like a cumulative pooling over time. So maybe we could find even the point in time which year we could have said that we have the sufficient evidence for the advantages of including this new method. I don't know, what is your idea on that? Do you think that might have been also like a time-dependent improvement in the outcomes? That may be more experience with the implantation method? What do you expect on that? That like newer studies maybe show better results? So
the funny thing is that we did the meta-regression also.
With respect to date of publication?
Yeah. So we did the meta-regression, but we cannot see any beautiful results. So,
But the result needs to be true, not beautiful.
Yeah. So we did, and also in the publication we added the meta-regression part, and the article title was time-dependent analysis of this, but it's just so we try to write it really sophistically, but it's not a big statistically good analysis or
yes,
something.
I mean, meta-regression is a very sophisticated method with a lot of conditions that is very difficult to meet, but making a cumulative by a year is pretty simple. So maybe, even if it's just for your interest, if you don't want to add it to the article anymore, but I would like, could we just switch to the next one, please? Yes, here is also, yes, on propensity score imaging. Okay, to the next one, please. No, I think basically you have addressed all my concerns. Thank you very much, and congratulations to the presentation.